Welcome back to ACCEL for February 2012. Disc 3 begins with Glenn Hirsch and Dr. Joseph Drozda, the Director of Outcomes Research at the Sisters of Mercy Health System in St. Louis, Missouri, discussing new performance measures for coronary artery disease and hypertension.
Thanks for being with us today, Dr. Drozda.
My pleasure.
Maybe you could start by at least distilling what are all these abbreviations and what does this mean?
These measure sets were developed under the auspices of the American Heart Association, American College of Cardiology, and the AMA convened Physician Consortium for Performance Improvement, PCPI. It's a lot easier to say PCPI. The PCPI has actually been around for over 10 years and is an organization of organizations. It represents multiple specialty societies as well as other professional societies like the American Nurses Association, etc. And it has existed primarily to promote quality improvement through the use of performance measures. And ACCAHA has a task force for performance measures, has been working with PCPI in the development of measure sets over the years, including heart failure and the current measure sets on coronary disease and hypertension.
So there are specific tools that you have developed, correct?
The measures themselves we consider tools for quality improvement.
Maybe we can talk a little bit about, there was an original set in 2005, and this is an update to that and maybe how it differs, but then get into a more granular level of what exactly does the performance set consist of.
The 2005 measure was developed by ACCAHA, PCPI, and addressed both coronary disease and hypertension. Those measures dealt more primarily process measures. They looked at prescription of medications primarily. Over time, I think we've seen the need to get measures more towards the measurement of outcomes rather than just processes. In revising the previous measure set, we tried to address those sorts of issues. Quite challenging to do that, especially at the physician level. And I think it's important to point out that these are performance measures designed for measurement at the individual practitioner level. They are designed primarily for quality improvement, but we also realize they will be used for what we refer to as accountability purposes, for pay for performance and for public reporting. So we wanted to design these measures in a way that they could be used in a fair and equitable manner for physicians and for their patients. So as we started to look at issues like outcomes, we ran into challenges with respect to statistical meaningfulness because of such small numbers for each individual physician. And when you start looking at things like mortality, etc., we got a little bit creative in the way we tried to get at outcomes, and I think maybe an example of that is the two measures that we tried to pair. One is a measurement of anginal symptoms and activity level, and the other is measure of anginal management. What we're looking for and what we're measuring is whether or not physicians are on a regular basis, in this case it would be annually, assessing all their patients with a chronic stable coronary artery disease for the presence or absence of angina, and also assessing their activity level. We know that patients may not experience angina simply because they've reduced their activity to the point that they don't have the symptoms. So you need to obviously assess both. The second measure says, once you've assessed all those patients for the presence or absence of angina, are you adequately addressing angina if it exists? So we're looking for a management plan when we find the angina still persists in terms of medication or referral on for revascularization. So that's how we address an outcome, which is very important to patients, and that's freedom from symptoms, without actually measuring the outcome itself because of all of the issues around risk adjustment, stratification, etc. They could not be adequately addressed at the individual physician level.
Well, you mentioned those as a couple of components of this performance measure set. So that's for the coronary artery disease portion. What are the other components that would be in that?
In the coronary artery disease measurement set, we also have a measure of blood pressure control, another one for lipid control. Then there's a measure of tobacco use screening and cessation, and antiplatelet therapy, beta blocker therapy, and ACE-ARB therapy. And we've also now added a ninth measure, and this one for referral to cardiac rehabilitation for appropriate patients.
One that's been greatly underutilized with a mortality benefit. Just to clarify, it sounds like this is really done at the individual level. Like, what's the mechanics of somebody actually using the performance set?
The measure set is actually designed so that it can be used in multiple ways. We've put out specifications for use of these measures in the electronic health record, and in the paper record, in which case it would have to be manually abstracted. We've also put out specifications for the use of these measures in claims data sets and in multiple electronic data sets. So when you've got information coming from the electronic health record, maybe pharmacy claims and hospital claims and outpatient claims, we have specifications for all of those. So these can be used in multiple ways.
Well, it sounds like that you've moved a lot from the process to actual measurement and a practical aspect of this, of measuring the actual outcomes, which is really important. We've talked about the coronary disease performance set. Could you just briefly mention what's included in the hypertension performance measure set?
Actually, we have only one measure in that hypertension measurement set. Is, however, a combination measure. The previous set actually had two measures. One was just a measure of whether or not you were actually taking a blood pressure with every office visit, and the second dealt with managing blood pressure if you found it to be elevated, in other words, over 140/90. The current measure reads that the percentage of patients age 18 years and older with a diagnosis of hypertension seen within a 12-month period that has a blood pressure of less than 140/90 or has a blood pressure of over 140/90 and is prescribed at least 2 antihypertensive medications. So we're looking at patients who have their blood pressure under the target of 140/90, and we're also looking at patients who have blood pressures over that target, but whose problem is being addressed with at least 2 medications. That was actually a population that sort of fell off the radar screen on the previous performance measures.
Well, these are helpful tools to give some consistent measures for the clinician to use to evaluate their own practice, but also maybe their entire practice or even at the larger level, at the university level, etc. Since someone would be going through all the trouble abstracting these records, is this something that would be useful in the Pinnacle Registry or for performance improvement in terms of maintenance of certification?
As a matter of fact, as we speak, these measures are being integrated into the Pinnacle Outpatient Registry, which the college continues to commit significant resources to, and the Pinnacle Registry has been found to be very useful for practices who have participated in the PQRI program and going forward the PQRS program, and practices who have participated through Pinnacle have had significant success in getting their bonuses. Pinnacle will continue to help physicians in that regard, but it also is now being used as a source of performance measures for internal quality improvement and for maintenance of certification. We actually have at least one program using it right now that the college sponsors in atrial fibrillation, another topic for another day, but the intent is to grow those maintenance certification programs using Pinnacle data.
We really appreciate you coming by today to talk with us and participating in this interview to update us on new performance measures for coronary artery disease and hypertension, which really is a practical set of measures that any clinician or practice could use to assess where they are in terms of quality measures and how their outcomes are doing now with coronary artery disease and hypertension.
Exactly so.
Thank you.
Thank you very much.